Hello and welcome to the removal of sex as a classification variable. My name is James Caddy. I'm a health information manager working as a classification manager in the acute care classification section. I'll be taking you through some of the changes that we've made to the ICD-10-AM ACHI ACS classification systems for 12th edition and the ARDRG classification system for version 11. So Australian jurisdictions have been evaluating the need to collect and report a patient's sex or a person's sex as part of their identity for things like birth certificates and passports. These evaluations have prompted further investigation of scenarios where sex is collected and reported, such as the provision of healthcare. So, are you male or are you female? It's a common question on intake forms, but what is actually being collected, and are the people that are answering these questions basing their answer on biological characteristics or who they identify as? Sex is biological and gender is sociological. Both use similar terms, i.e. male and female, but refer to different concepts. However, is the binary, is that useful in order to be able to collect information from patients or people in general? While typically based on sex characteristics observed and recorded at birth or infancy, a person's reported sex can change over the course of their lifetime and may differ from their sex recorded at birth. Sex can also be a broad term that covers characteristics that describe chromosomes, hormones, reproductive organs, and anatomy. However, gender is a sociological-based concept and may not align with someone's biological characteristics. On the screen, you can see a diverse range of the different terms and concepts related to the biological and sociological concepts that we may associate with male and female. And sometimes there is a third option of another term or other to be able to classify the things that don't distinctly fall in between male and female. So why is this a problem for hospitals? Basic data is collected from hospitals to understand why people use them, as well as funding health services and planning for the future. Clinical information is captured using health classifications from medical records, documented by clinicians. However, patient information, such as sex, is self-reported. The problem with collecting self-reported sex is that some people prefer to report their identity rather than biological sex, may not understand those differences as well. In addition, sex can be many different things. Someone may know their external anatomical biology, but may not be aware of any atypical characteristics in their hormones or chromosomes, or even their internal biology. To ensure quality data is collected, the classifications are supported by attributes that have utilized patient-reported sex to verify certain conditions. For instance, pregnancy, which is only possible for the female reproductive system. However, where we collect sex and people report their gender, there may be an inconsistency between what we're expecting to see in the patient administration systems. So ICD-10-AM is a classification of disease. ACHI is a classification of intervention, and both of these classifications use sex as an edit. And these edits have historically been inconsistently applied to different codes within the classification system and to all elements of sex characteristics, so hormones, chromosomes, anatomy. The ARDRG classification is a classification of episodes of care. So it uses the sex conflict test and sex as a classification variable. However, grouping anomalies, so where the patient reported sex doesn't match what we're expecting to see on the underlying codes of ICD-10-AM and ACHI, may cause health services to change their data to avoid the errors in the data submission and this ultimately makes them less accurate. So we have health services that are treating patients, that are seeing patients, that need to change their data in order for them to be passable through the DRG classification system, and removes that accuracy of the data collected at the jurisdictional and national level, which is not what we want. And it doesn't correspond to how we use the data for disease trends, research, funding purposes, including activity-based funding and private sector funding, as well as health service planning. So what does this look like? The ARDRG classification system classifies episodes of care by using classification codes. And in some areas of the classification, the self-reported sex is used to verify and also group episodes of care. So in the scenario on the screen, we have a patient who identifies as a male, and they've done this in the patient intake form. However, the patient has a hysterectomy during their episode of care, and it is due to cervical cancer. So the health classifications that IPA updates of ICD-10-AM classify that to C55, the cervical cancer, and the intervention of the hysterectomy is classified using ACHI, and both of those have sex edits on them. So when the patient reports that they're a male, the DRG classification, the episode of care classification, groups that to an error. So that's 960 in the DRG classification system, which is not funded. However, where the patient reports or in the administration system, if that's entered as female, it will group accurately and it will go to uterus and adnexa interventions for malignancy. However, you can understand that the patient-reported sex doesn't actually make that difference in reality, where the documentation by a clinician has documented cervical cancer and a hysterectomy. So what do we need that classification of sex for? IPA's looked into the classification and the different codes that require sex in order for the episode to be classified into a disease of the male or female reproductive system. That's how it's grouped in the DRG classification. IPA reviewed the codes requiring those and developed new codes with additional specificity that reflected the biological characteristics documented by the treating clinician during that episode of care. So in the scenario that a patient has clear documentation of biological characteristics, but you can't capture that in the classification, we can see this playing out in the previous editions of the classification ICD-10-AM with T83.4, which classifies mechanical complications in the genital tract, but it doesn't identify the fact that it was a penile or male biological genital tract. So IPA created additional codes for the new edition, 12th edition, that specifies this and is able to therefore use that classification code to direct the coding without the need for the patient-reported sex. Sorry, lost my place. So what IPA did to classify or to enhance the classifications, it took the review of the 67 principal diagnosis codes that use sex as a classification variable, and it created 38 new codes that specify the sex characteristics in the code title. 28 codes were relocated to more appropriate groupings within the classification system, and one code remains in the DRG version 11 that requires sex to inform grouping, so sex as a classification variable. Changes were also made to the health classifications of ICD-10-AM and ACHI, and they've been reviewed to ensure that the edits align with the reproductive system rather than the concepts that are commonly associated with one sex over another, such as breast cancer and stress incontinence, both of which can affect people regardless of their reproductive organs and had previously had sex edits on them, restricting the accuracy of the data collected. Guidance has also been included for ICD-10-AM and ACHI to ensure that the trained clinical coding workforce knows how to apply male and female codes so that they align with the biological characteristics documented in the medical record. This is important as clinical coders are the workforce that are responsible for collecting the health classification data, and they've been trained in medical science and understand how to apply these concepts of male and female. The new versions of the classifications are now being released, and IPA will be releasing education in mid to late May for the 12th edition of ICD and 10-AM and ACHI and version 11 to help with the health information workforce to understand the changes for the releases of the classifications. Further information can be found on IPA's website, and I thank you for your time.